We did it.
Yay!
Hello, everyone. Thank you for joining us. I guess we'll get started. It's already a couple minutes after 4. I'm Jocelyn Fitzgerald. I'm the social media editor of the Urogynecology Journal, and welcome to our second installation of By the Scrub Sink, which is a written paper in every issue of the Gold Journal where we ask experts. Today I have Dr. Pamela Moalli, who is going to talk with us about what she would say to her fellow or to a co-surgeon standing at the scrub sink about to do a minimally invasive sacrocolpopexy. So many of you enjoyed the one that we did about uterosacral ligament suspension a couple months ago with Dr. Merriweather. So now we're very excited to talk about a different type of apical suspension. So welcome, Dr. Moalli. Thank you for joining.
Yeah.
I always, even as an attending surgeon, sometimes like to sneak into Dr. Moalli's operating room to watch her she's a master at this operation. So maybe you could just sort of tell us, you know, your experience with sacrocolpopexy, how long have you been doing minimally invasive sacrocolpopexy, and, you know, why do you think it's a good procedure?
Sure. Yes, it is my favorite procedure, I must say, and I have been doing it since 2000. So embarrassingly, that's a whole 24 years, or almost a quarter of a century. Wow.
But that means you're good at it.
Yeah. So we started, doing them open, and did them with started doing them with abdominal rectus fascia at first. And then with the morbidity associated with that and the extra time, we then moved into polypropylene mesh. And then I can't remember, somewhere between 2010 and 2015, I began to do them minimally invasively. I just said, okay, I'm not going to open anybody again. We're going to do these minimally invasively. And I was a very awkward surgeon at first doing them. But I think I've done over 1,000 at this point in my career. Yeah.
I've no doubt that's true. And there is, not to flash forward too much, but one of the upcoming By the Scrub Sinks that's coming up in a forthcoming issue does talk about, like, a little bit, we're still talking about sacrocolpopexy open versus minimally invasive. What did you notice when you switched over to minimally invasive? What were the changes in the patients or the outcomes?
Yeah, I feel like what I noticed first of all, when I used to do it open, I always removed the whole uterus. So I've started, based on some of our research, to about 75% of the time, I think I keep in the cervix. So I saw a few more mesh exposures. I would say probably what the standard is 8%. But also the patient recoveries were so much better using minimally invasive surgery. For me, I know there's been studies when people do, and we used to do, sometimes I look back at the incisions. There are these teeny tiny incisions that we were able to do them through, but I still think they did better with the laparoscopy incisions, and yeah, same with robotics.
And I think the studies have borne that out. So the majority of surgeons these days doing urogynecology, I think, are doing minimally invasive sacrocolpopexy. So the beauty of this series and of the paper in the journal that I hope you all take a look at is that this is supposed to be like by the scrub sink. These are tips and tricks from the masters of these surgeries. So Dr. Moalli is very well known for her expertise on mesh, and one of the first headings on this article is choosing a mesh. And I think if Dr. Moalli recommended a mesh, I would be the first one lining up probably to buy it. So maybe you could just tell us about how you choose a mesh for your procedure.
Yeah, well, I think that it's 2 decades of research, and one of the shortcomings of the materials that are available on the market today is that they were really never designed specifically for the material properties of the vagina. The vagina is very soft compared to some of the other organs, or like the abdominal fascia, I would say, was the most common other indication. And so it needs to be extruded into thin fibers and then knitted into a pattern so that it moves a little more with loading, and it's overall a softer product. Like if you had a solid piece of polypropylene, right, that would just be awful.
Yeah.
So then when within meshes, though, so we used to think, okay, just go lighter weight and that would be fine. But what we find is that you really have to take into account the loading conditions. So meshes are loaded very uniaxially, meaning one direction, sacrum to the vagina. And that particular loading condition causes the pores to be unstable. So what we've shown is the geometry that's most stable is the square, and it's really difficult to make that square deform if you're loading it. So
yeah, you see that.
Yeah,
when you're pulling on it.
Yep, and a quick test is just switch it to the diamond, and you'll pull on it, and you'll see they're all collapsed. So that's stable. Some people can stabilize a mesh sometimes, with their suture boundary, the way they suture it in. But really, if you go with the square pore, it's going to be stable.
Yeah, I think that we talk about that a little longer, but a little later in the paper. But since we're here and we're talking about, you've chosen a mesh. You mentioned is the weight of the mesh and the shape of the pores are both incredibly important. Mm-hmm. In order to keep that shape of the pores, what is your technique when you're affixing the mesh to the vagina in particularly?
Yeah. So you want to make sure, basically what I always tell the fellows is you have to make sure you load it on the square. So to do that, we really, I tend to sew the posterior strap of mesh. I use a Y mesh, and I tend to sew the posterior arm first, and I use a Scheiden. I guess the rest of the world calls it Breisky.
For those of you who don't practice at McGee.
Yeah, so I use we call it the big Scheiden.
The big Scheiden.
Yes, the big Scheiden. So it's like 5 centimeters across.
Yeah, it's quite wide. It's about the size of a 2-inch deaver, which we use deavers when I train to get that posterior lift, like a 2-inch wide deaver.
That's a great idea.
But
that has a curve more, right?
It does a curve, so you can really flip it up. Mm-hmm. But I have found since being here that the big Scheiden works just as well.
And that's why I use it over the EA incisor, because the EA incisor doesn't go all the way down to the to the perineal body or perineum. So so we use this really giant Breisky, and we're able to keep the mesh flat and on the square. And then when you're going over to anterior, you want to make sure you want to look at how your posterior is positioned so that you can line it up with the anterior strap as well.
Okay. When you are sewing the mesh on, do you have any recommendations for the geometry of the sutures? I've heard some things about people who say you should never put one distal suture because that not loads more than if you put them side by side, or people who put it inside the borders of the mesh versus going around the mesh. Do you have thoughts on that?
Yeah. I don't have strong evidence, but I do know that your apical sutures are going to be loaded the most. So I do try to, if you just have one suture on each border, you're going to see it buckle in, right? You're going to see a wrinkle in when it's pulled, or it's tensioned, So I try to put 3 or 4 across the apex, and then I'll put them on the borders. Occasionally, if I see a little buckling or wrinkling, I'll put another one to flatten it. Okay. But mainly, I really try to make sure I get at least 3 across that apical border. Anteriorly and posteriorly.
Wonderful. That's very helpful. Great. Well, I think that kind of covers that. I think a lot of people have questions about where sutures should be placed on the mesh. I think there's a lot of variation in practice there.
Oh yeah, you asked if you put it. Some people put it completely inside the mesh. I tend to go two pores in and then a little lateral to kind of pull it flat. But I don't think either. There's no evidence for either. Just as long as you're keeping it flat.
But yeah, I think I was pretty much taught that as well, that you can start externally to the mesh as long as you go through it, and then when you tie it down, it keeps the edges. And agree. I also will sometimes, if you see it, it's nice to maybe have that middle one. Just to see it being held on the middle of the vagina, but I'm sure it doesn't make that much of a difference.
Yeah.
Okay, so we did talk about where we start the surgery. You and I think I both start the surgery at the sacrum when you go in. So hysterectomy or no hysterectomy, tell me about why you start at the sacrum.
I started that as soon as I went minimally invasively. It sort of made sense for me to start at the sacrum because that's the most difficult part of the case, right? That to me is where, you could have the mesh all attached to the vagina to get to the sacrum, and you have something that precludes you from being able to complete that dissection. There's not much where you know, nowhere you can go, you know, so then you'd have to take it off the mesh. And so it's very rare that I think I've had to abandon 2 sacrocolpopexys. But you can get in these women, and I don't know if it has to do with the etiology of prolapse, but you can get these really, and you had one the other day.
Yes, I did.
A very flat, flaccid left common iliac vein. Now, this is if you attach the mesh to S1, and I have my reasons for doing that as well.
Yes.
But so you can have this flaccid vein that really doesn't give you much of a space to attach to. I've occasionally kind of moved it out of the way. I'm not sure how smart that is because I'm not sure you really want mesh.
You have to be a masterful surgeon to be comfortable with that, I think.
I think we did have a case with one of our faculty here who I was called into who had a very low-lying right common iliac artery, which is a little more amenable to retraction. So we had one person retracting it way out of the way while we dissected down to the sacrum. But the iliac vein, if you have a venous injury, it's much more devastating because they're more difficult to repair. Yeah. So they do occur. So yeah, you have to be aware of that. So and then the other person, or I think that you have to be aware of is the little skinny. Or we all love skinny people, but the skinny osteoporotic lady who's lost, has had compression of her spine, and now she's had descent of her aortic bifurcation. And her IVC, so then now that can really preclude you. I mean, it could really distort the anatomy, some of these ladies' spines. And I think that was one time where I could not figure out, what was what. And we had to do a laparoscopic uterosacral instead of a sacrocolpopexy.
Yeah, fascinating. Not to, again, jump around, for those of you reading the paper, it is organized very nicely in a few things, but when something interesting comes up, I may deviate slightly. Do you have... Let's talk about the patient that you choose. I like to talk about picking the patient for sacrocolpopexy. Do you have a lower or an upper limit of an age for sacrocolpopexy?
Oh, that's a good question. Well, I think I would look at their overall fitness. I tend to shy away from them over the age of 75, but I know there's a lot of people that do them over the age of 75. I'm more concerned about the host response to a foreign material at that age, but there's been no evidence. There's evidence, in vitro evidence and stuff, that you don't mount as good of a immune response, a healing response as you get into your 80s, but I don't think that's ever been borne out, and certainly people get arthroplasties and, total knee replacements, different things. So, yeah. I don't know, but and young, I've done them on people in their early 30s. I haven't had too many patients in their 20s, but yeah.
I think early 30s is the youngest I've done as well. I wasn't super excited about it, just like I'm not super excited to do it in women. Yeah, over 65. There's a newer paper that came out recently that showed kind of everything symptomatically is similar over 65, like everything we do. So I'm not super hot to do it, but I will do it in a very fit patient, in the right patient.
Yeah. Well, in Pittsburgh, we have a lot of obese patients. I mean, it's very unusual to have a normal weight patient.
Yeah.
And so I've learned to really, and especially the older patients, I've really learned to embrace the fat. I'd much rather have an overweight patient than an underweight patient for this procedure. So it's interesting.
Yeah, that is interesting. Let's go back to that really quickly, because we talked about the sacrum, and I think the sacrum is, for most of us, the scariest part of a sacrocolpopexy. It's the part that makes us sweat. So, and we just talked about there's can be all these large vessels sometimes underneath what you can see at the promontory. So if you have someone with a lot of fat on their sacrum, or you just can't see all the structures perfectly, how do you decide where to start? And also, what is your technique for, especially with a trainee, making sure you don't get into anything dangerous in a fatty sacrum?
Yeah, I know, that's the tough part. It's interesting because I've done a lot of these on primates who have a lot of belly fat. So I've kind of learned the anatomy really well. So if you go immediately next to immediately medial to the sigmoid, there's sort of a thinning in the peritoneum, and that's usually what I target. You know, especially in a very heavy person where you really can't even, you know, you sort of palpate where it is, and then you can go, you know, pick that as your starting point. But there are times when I'm off, and you usually can tell that you're off. Like if you're too close to the sigmoid, you won't get that loose areolar tissue. Mm-hmm. And then if you're too close to the sidewall, you're going to run into something pretty quickly. Usually the right common iliac. Yeah. But I usually just kind of, I use an end seal, and I usually kind of just, you know, dissect down. I usually, you know, seal and spread, raise up so that you're not going to hit any vessels, and then have your, you know, assistant drop it so that you can see what you've done. Because if you lift up, you lift away from the vessels, and then once you drop, you can kind of see the vessels again. Really, really, really meticulous hemostasis, because once you get bleeding, then you lose all, you know, normal anatomy. You know, it's really much more difficult to see. So I'm really, really particular about, you know, making sure that I have thrombin ready, you know, anything that I would need in case I would run into bleeding.
Yeah, totally agree. And I also do that lift and
drop,
lift and drop, to probably the annoyance maybe of the fellows sometimes. I'm like, stop, we need to see where we are.
Yeah.
And the other thing that's sort of, I've had a couple cases where I've been almost saved by the pneumoperitoneum, which has almost like dissected through that areolar bubble and kind of shown me where to go.
Exactly.
I don't know if that's luck, but that's the beauty of, I think, the pneumo and the minimally invasive, is that it's a tool for dissection.
Oh,
sometimes.
no. Open over the sacrum used to be beautiful.
Really?
You could just go down. Yeah, it was.
There you are.
Yeah, but well, it was beautiful too, I guess.
I'm sure it was very lovely. Some days I wonder what that would be like. Okay, so some of the next, we talked a little bit, one of the things here is defining the anatomy, and I think we did sort of just talk about kind of where to start, but just for the audience, what is the relevant anatomy? You mentioned the sigmoid and also the right common iliac. Like, what is the other anatomy you look for?
So first of all, so you look into the pelvis to identify where the sacrum is. Some people have a little bit of a rotation from a kyphoscoliosis or something, so you sort of palpate where it is. And again, in Pittsburgh, a lot of times you can't even see. You have to really, you know, take a retractor, usually Pennington, and just kind of go back and see where, you know, S1 is. And then, I always try to see where the bifurcation is. Right common iliac artery, left common iliac vein are usually your troublemakers, but you also need to know your ureter. I typically stent patients. I stent a lot of my urology training. But and then obviously when I have a thinner patient and I can see the exact position of the middle sacral vessels, which I always seal, I kind of note them, then go over them. That's where I would enter, basically. But and when I'm there, I always make sure I find those vessels, because I just feel like once you're attaching the mesh, and whether you sew it in or you tack it in place, you know, if you have some underlying vasculature, it's kind of too late, right?
Yeah,
so
right.
so I always get accused of making this S1 bald, but I really make sure that I really can see the ligament clearly, that there's no any fat on it. It doesn't really have that peritoneal layer or that sort of loose connective tissue on it anymore. I really want to see a clean ligament, and then I seal my artery and vein.
Yeah. I've actually learned a lot about your techniques from operating with our fellows, I guess, because we didn't have the end seal where I trained, and I know that's like a sort of unique device. But I really like how the fellows have showed me, like, because it gets hot on the tip, and it's flat, you can kind of push and kind of clean. What do you call that?
Jimi Hendrix.
Oh,
interesting. Jimi Hendrix it. We go up and down. Yeah.
Up and down, yes. So the fellows do that in my OR, and I love it.
Yeah.
I think it's a really great way to clean and just like get hemostasis on the sacrum. So I'm a big fan. I let the fellows do that in my OR after being with Dr. Moalli. Okay, great. So we've talked about the sacrum. I think we'll come back and talk about how we fix the mesh to the sacrum. But the next sort of things that we need to discuss, we've gotten our sacral dissection done. Now we're dissecting the anterior and posterior vagina. So the bladder and the rectum need to come down. So you said you do posterior. Oh, no, you put the mesh on posteriorly.
No, I do a posterior dissection generally first.
Oh, you do? Okay.
Yeah.
Just Tell us about that.
Yeah,
Maybe I should do that.
yeah. Why do I do that? I don't know. So I feel like especially if they've had a hysterectomy, that tends to be a more defined. If they've had a prolapse repair, I guess that tends to be an easier, more complete plane that you can identify. Yeah, and so yes, I usually do the posterior first. I do pretty wide, and I'm told I go pretty low. I go really close. I don't include the levator ani. I don't go lateral, include the levator, and I don't include the perineal body because I don't want them to have pain with intercourse. But I try to get as close as possible. Yeah. Because I feel like that is the crux of having a solid sacrocolpopexy is going down and getting that posterior wall really, really supported, and then obviously. We definitely, there can be difficult dissections posteriorly if they've had a posterior repair. So then I would use a rectal probe to kind of, you can divert the, rectum to one side, kind of see where it is. Yeah. And then, so then once you define that plane posteriorly, if they haven't had a hysterectomy, you can just go a separate dissection anteriorly. Sometimes what I find is that if they have anterior wall elongation, people used to call it kind of the wraparound bladder. Like the bladder can almost seem like it's going to be posteriorly.
Yes, absolutely.
Yeah. So if you do the posterior dissection, now you've got that plane started, and you can really go to a clear spot and then do your anterior. And for the anterior dissection, which I think is more difficult, I do sometimes repeatedly fill the bladder with fluid just through the Foley. And then, always look for the adventitia, the common, loose connective tissue between the vagina and the bladder, or the vagina and the rectum. So I say to the fellows, the fat belongs to the rectum, so you don't want to ever get in that fat, because then you could potentially get a rectal injury, or the nerves. And you don't want to get too laterally, so you don't get in the nerves and they don't get constipation. And then anteriorly, same thing. Go for that loose connective tissue layer. Although, sometimes it can be millimeters.
Really stuck.
Yeah, Oh, it can be really stuck too.
Yeah,
yes.
If they've had a hyst or they've had C-sections, it can be really sticky. But
C-sections you should be below. But if they've had an anterior repair or another type, a couple anterior repairs, it can be really bad.
Yeah, true. Or endometriosis. I've had some of those sort of stuck.
Yeah.
Going back to the posterior, so how do you tell the fellows, like, just nitty gritty, like how to start the plane? Do you have them grab, and are you looking for something specific, like right above the fat, and then how do you know you're in the right place so that you can go down super low?
Yeah, so we typically grab each side, one per, with a Pennington, and then so if you go too close. Like if you start too close to the apex, you're just going to enter the vagina, and then you're going to get in the wrong plane. So you have to kind of go to the space above, space between you where you see the rectum insert and obviously the top of the vagina. But I've had some pretty, people who have had either rectal abscesses before or endometriosis, where it's like really difficult. And so my rule is always, when you're entering, I usually enter with monopolar to kind of let the fat go away, just to go through the peritoneum, and then I kind of bluntly dissect until I see the vagina. If you start seeing obviously longitudinal fibers, that's rectum, right? And that they might have an obliterated cul-de-sac or something, and you're going to have to enter higher. But that's rare, but it happens, and that would obviously be devastating if you get into the rectum. And one time I had a medical student, which I never thought of this until then, and now I always check, put the shot in the rectum.
So I've seen that before.
Yeah. And then, so I was able to see, so definitely you go through the peritoneum, you're going to hit fat, and then you need to see that white, nice vagina, that you're always trying to get to. And once you're between the fat and you go between the fat and the vagina, that's your plane. And then you can once you get there, you can follow it all the way down.
Perfect.
But too close to the vagina is bad too, because it just bleeds.
Right, it bleeds. When it bleeds, that you're splitting the vagina.
Mm-hmm.
Yeah, absolutely. That's hard. Okay, really quickly, before we move on to tensioning, because we actually already talked about the mesh placement and how we sort of sewed on. Really briefly, I think a lot of people get this question, especially fellows, like, how do you deal with deciding if you're going to finish the surgery if you get God forbid, well, a vaginotomy is not terrible, but a vaginotomy, would you repair that and place the mesh? And then what about a cystotomy? Would you?
Yeah, I do. I do. You know, it's, I'm not gonna put it, it's worked
very
so far.
Rare, very rare thing.
No, but it happens. No, I think cystotomies are more common on somebody who's had prior prolapse surgery, hysterectomy, and they just don't have any planes. And I think that you know, it happens. I certainly have had at least 5 cystotomies on these or more.
Sometimes the bladder is paper thin.
Yeah. So sometimes I even counsel my patients if I know they've had, if I'm on their this is like their 3rd prolapse repair, I will say ahead of time, you know, sometimes, because this is true, we'll have to make a little window in the bladder, and that way we know, okay, there's bladder, and then we lift that, we know there's vagina, and we lift that, we know where's rectum. Because sometimes if you're dissecting and you really can't tell what's what, and you have a little tiny cystotomy, then you're like, okay, that's bladder, and then let's go down. But a lot of times they're tiny, they're super tiny, they're like a centimeter or so. But if it's someone who's had a lot of surgery, I would put a cellular bioscaffold, typically matrix stem, just a single ply, because that's the most regenerative, in between the mesh and the
bladder.
Mm-hmm. Yeah.
Okay.
Yep.
Yeah. Which actually then we'll talk last about retroperitonealizing the mesh, which sometimes is a challenge, but first we need to tension the mesh. Now we've attached our mesh anteriorly and posteriorly. We've made it nice and flat. We have our beautiful sacral dissection.
It's true.
Tell us a little bit how you prepare your mesh. How do you cut it? Do you fold it over the sacrum?
So I use the Restorel Y, which, as you know, in a study out of Duke, they found that it failed more often, you know, from the start, ever since I started using that mesh, I realized that I was making a modification that was probably really, because we haven't seen any failures at Pittsburgh so far.
I don't think I've ever seen a true sacrocolpopexy failure.
No, I mean like where the stem lets go.
Where the stem lets go.
Yeah. So I do, this is a great medical student task. You know, I fold, so it, you know, you have each arm is the same weight, but I fold over the stem right to above the crotch, and I, you know, fix it in place with 3 sutures. And then sometimes I'll put 2 little sutures on the side. So that way we've loaded, now it's gone up to from 18 grams per meter squared to 36 grams per meter squared.
Yeah, I love that trick.
Yeah, which is, you know, pretty good, but it doesn't really matter. We'll be developing graded meshes hopefully over the next 5 years, but you know, all these adaptations we have to make, but it doesn't really matter what's in your stem, right? But that's a really important load-bearing structure, right? So that's why, I fold it over. I don't tend to do it this way. Some people I see do longitudinally, but that kind of brings the edges more distally in. You would worry about wrinkling. Okay. Yeah. So I do it transversely.
Yes, that makes sense. I think I do the same, which I didn't train to do that. Sometimes we would fold it over, but I like the pre-fold. It makes so much sense. Yeah. And it does make it like kind of fit in that space a little nicer. It fits really well. I never trim. Yeah, I never trim. It's lovely. Yeah. So it kind of fits right in that spot, nice and sweetly, and then we tension, and most people I think here at McGee use a tacker, which I've also embraced, and I sort of love because I think it makes it flat. Makes it flat. And maybe you could just talk about like the biomaterials and why you like to tack. It also saves me from having fellows throwing sometimes some scary sutures when the needle comes out. Yeah. Although if you're not sure you've secured the vasculature, it's obviously safer to suture around the vessel. Because then you would just tie down your and that should stop. So so I went to tacking when we started showing that it wrinkles, and again, same thing that I was talking about. Any deformation in a mesh increases your risk for complication. Not everybody who gets a wrinkle in their mesh is going to get a complication, but those abnormal stresses on the vagina are just a setup for both fibrosis and stress shielding.
in a very complicated explanation. But so if you tack boom, 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 4 across, another 4, 2 rows of 4 or 2 rows of 3, you're loading it very equally. Once you do sutures, you tie them down, unless you tie them really loosely, I guess, but everybody wants it tight, right? Because
exactly.
they don't have to fail. It automatically wrinkles the mesh.
Yeah.
So you're starting out with a wrinkled situation. So that's why I do that. Wrinkles in any biomaterial are not good. A soft tissue likes even Steven stress distributions. It doesn't want high low, high low, high low, which is what a wrinkle does.
Right.
And then I forgot what else you asked me.
Oh, I think that was pretty much it. Any other what are the tacks made out of? Like, is there? What would you say to someone who says
I don't think
metal on the sacrum? Is that okay?
Yeah, we did a retrospective study to see if we had any sacroiliitis or anything like that. We haven't had any. There's no difference in suture, and but you don't know if they went to another hospital or something. But so far, we haven't had any.
Yeah.
I mean, we use I don't think you need permanent, but I use permanent. So we use the capture right now, which is a little steel, but we used to use I can't even remember what the name of it is.
The ProTac? Is that what it was?
Yeah, the ProTac device, which was titanium.
Titanium.
It was a little titanium spiral suture. And I know people like Sean Menifee are now moving to dissolvable, which is probably fine, because when we do them in the primates, we always use Vicryl, and it's fine. It heals in really well.
Yeah. Interesting, because there definitely was a shift, I think, in the last, you have to tell me, 10 years from Gore-Tex on the vagina, permanent suture on the vagina. Now
I know, it's
really
such a lovely
no
suture.
One does that.
No, we shouldn't.
But we do still have permanent on the sacrum. I do really like that it makes the mesh. You can tack it in 4 corners and make it flat.
Yeah. We used to use Gore-Tex meshes too, but Gore-Tex suture or mesh is microporous, so it has little tiny pores in it that bacteria can't get into, but your immune cells can't get into. Now, if it was super soft, they probably could squeeze in there and get rid of the bacteria, but they can't. So we would see, I didn't really know what it was. We would see these sort of sinus tracts to the mesh and stuff, which is sort of a biofilm and this subclinical infection.
Absolutely.
From just harboring bacteria. So you can't really mount this huge immune response because they're hiding in those little spots.
In those things. Yeah. I know I've thought about this. Obviously, sacroiliitis or a discitis is super rare, but it seems like if you have a sterile titanium or stainless steel tack coming out of a sterile device, that seems cleaner than dragging a suture, through a cord, even though it's a sterile environment, and pulling that suture
I didn't even think about that. That's a really good thought,
It just seems cleaner.
Yeah, that's true. I didn't even think about that.
Anyway, that's why
that's true, because it's coming in, it's coming out, you don't touch it at all.
Right, you don't touch it at all.
Yeah.
And the suture you do, even though obviously
that's a great idea.
Sterile, so here we are, just ideas. Okay, so now how do you decide when the mesh is the tension? How do you decide the tension of the vagina? Do you eyeball it? Do you have a system?
Yeah. I found that I probably didn't tension enough when I started, and I started seeing, so it's because I go to S1, so if you go to S2, S3, you're going to have more posterior failures, right? Because the posterior arm doesn't go as far as the anterior arm. If you go to S1, it's kind of even Steven, so you kind of reduce, not completely, but you reduce those posterior failures. I put the Breisky in the posterior compartment, and just enough, not like a ton, but enough tension, so
gentle elevation.
Yeah. That say you're, especially in obese people where one of your, hands is trying to retract the peritoneum, the fellow's trying to pull the mesh flat over the sacrum, you still have to see where the sacrum is, right? So if somebody's kind of taking the role of, you're not actually having to lift it, and you're just having to place it. So but they put enough tension so we don't really have to do anything ourselves.
Okay.
And then I just, go that way. What is if you use so what happens is when we put something in 5 centimeters and it's now loaded by something that's 4 centimeters, there is a little collapse in and loosening with the way we do it.
Okay.
But if somebody uses a narrower device, right, they may not want tension. They might want to go really firm and then back a little bit, because we're going 5 centimeters to 4 centimeters, so we get a little bit of laxity automatically.
I see, on the side too.
Yeah.
Okay.
But don't you think that compared to how you tension them in surgery, there is a little bit of relaxation?
Yeah.
Just a little bit in the
Sure.
first 12 weeks after surgery.
I think definitely. You even
Yeah.
see it like when you take the pneumo down sometimes. I always like to
Yeah.
watch the
Yeah.
valve go. I like to watch the large valve go down first to keep the small one out of there.
Yeah.
But yes, it does seem like as soon as someone changes position, like from
Yeah.
laying flat, that there's
Yeah.
already going to be
Yeah.
relaxation.
Exactly.
In it. So yeah,
And we don't cover the entire vagina. There's all these, adjustments in the lateral
It's
walls.
not like we're putting a circular tube of mesh on.
Thank God.
Yeah, thank God, exactly. And then, so the last thing that's on here, well, we'll talk about checking for injury, but do you retroperitonealize your mesh?
Always.
Yes.
Yeah.
What if it's really hard? What if it's like a
Yeah, that's a really good question. Well, and then there's the times where I completely forgot to, every once in a while I'll be like, oh God, we didn't make I just sort of, so when I make my sacral dissection, I just go down, between the sigmoid and the ureter. Yeah, and just
down to the uterus sacral.
Go right to the uterus sacral.
Mm-hmm.
And then I sort of mobilize it so that it's free and it will lift and cover. But every once in a while we're like, oh damn, we forgot to do that.
So you're down.
trying to do that. So, but if you have somebody who's scarred, you're on 3 or 4 prolapse repairs, they don't have a really pretty mobile peritoneum, or some people are really stiff in general.
Yeah.
I will use Matrostem or something to cover it.
Okay.
Or you can, when I used to do them open, we used to kind of bring the bowel in, just sort of the mesentery, just sort of not, you don't want to use the bowel, but I kind of just can roll the bowel into that area and give you a little more.
Okay. I sort of do that too. If someone's, I just cannot tug it over. I always cover the sacrum, but sometimes low down, it's like, you can't. I
even bring the rectal dissection flap up.
Okay.
To cover the rectal, because one of my fellows, the first thing that happened when they went into practice, they had the small bowel got into that space and stuck to the mesh.
Right, I get worried about those holes. Like, you either totally cover it, or I'd rather it not be covered at all.
Yeah, exactly. So it just covers all the easy stuff.
Right, exactly. Okay, so I know that the jury's a little bit out on that, but it, I think
I do it just
harm ever came of covering.
It takes longer.
It does take longer. Mm-hmm. And there is some data that says like you might get more ureteral kinking, but I think if you mobilize, I don't know. Everything we do has a very low.
If your ureter is kind of coming in, folding in.
Yeah.
So if you're looking down into the pelvis and your ureter is folding in, just do some longitudinal relaxing sutures and it will just move back.
Oh, okay.
Not sutures. Incisions.
Like incisions.
Yeah.
Mm-hmm. That's a very good tip.
So I did have a lady who was really skinny. Again, the reason I don't like to and I was in the OR for a different reason, and somebody said, hey, your patient is back with MIGS, so minimally invasive general surgery. She has a bowel obstruction. I was like, wow, I haven't seen one of those in ages. So I go back there and they're just about to cut the sacrocolpopexy mesh because her bowel had gotten under the bridge and gotten sort of stuck on the other side. So after that, I was like, okay, I'm always, especially in thin women, I'm going to period. So we saved, she was like, when I told her afterwards that they were just about to cut her mesh, she was like, oh my gosh,
Yeah. I mean, there's
these are like, I didn't know what it was.
Yeah, I'm sure. They're like, what is this? It's just floating in here. Sometimes I don't know what their meshes are either. Yeah. Absolutely. I think it's all of our fears that those little nooks and crannies, the small bowel will find its way. And then the last thing, speaking of checking for injuries at the end of the case, we've avoided a vascular injury at the sacrum, hopefully a bladder, a cystotomy, and a rectal injury, but how do you verify?
Yeah, so immediately after I place the posterior arm, I always do a rectal exam. So, and I do it looking with the, so I have somebody doing it, because sometimes you know, like if you ask a colorectal surgeon, they're like, you'll never be able to tell, the rectum's so big. So
Sure.
So what I do is I put the camera down in the space and have another person or me, you know, somebody holding the camera or me doing the exam, so that you know you're actually feeling in your full dissection
up to where it is now.
And where your sutures are, to make sure you didn't accidentally pull up the rectum.
Yeah.
And then for the bladder, I do you know, so first I have my stents, not all the time, but most of the time, make sure sacrocolpopexy, before I leave laparoscopically, I look at the position of the ureter, because I know that if I go down, if it looks good, it doesn't look kinked, and I go down to the bladder and she doesn't make urine right away, I know I'm going to be more patient, right?
Sure.
So if I feel like it's really in a safe position, I'm going to be a little more patient. So always look before I go down to do the cystoscopy, and then we do the cystoscopy, and then we make sure we have, you know, no injury, and then bilateral flow of urine.
Agreed.
Yep.
Same, and that's, I think, should be standard.
Yes.
Anyone who's not doing that after sacrocolpopexy, that's a little frightening. But it is hard to really reach up there for the rectal.
The rectal,
that does. I mean, you can feel a lot, but like it's really high.
Yeah.
Once you're done.
Yeah, that one case where that we had the medical student put the Scheiden in the rectum, which is totally my fault. But I did have a colorectal surgeon come in, and I was like, can you just do a rectal? And I said I did a rectal, and it feels okay. And he goes, why? and then he goes, he usually sends air in,
like
so
bubble test.
Yeah, he'd fill with fluid and send air in. He said that's better if you're looking for little tiny things. And I was like, oh, okay. Fair. But I still do a rectal.
Yeah, I still do too. Yeah. It helps me sleep at night.
Yeah.
Well, that sort of got us to the end. It's what time is it? Okay, perfect. We've been talking for about a little over 40 minutes.
Oh, wow.
And we'll see if we have any questions. I know that Stephanie's moderating our chat. Oh, we do have questions. Thank you all for joining. This is exciting. Let's see. Oh, this person asked, their question is, if we can ask questions. I'd like to know, how many months would you wait to carry a prolapse repair? I'm not sure exactly. After a second time in a C-section.
Oh, how to do? How long after a second C-section would I perform a prolapse repair?
Oh,
I probably would wait a year.
A year, yeah.
It's interesting to me because, so a C-section, that's interesting. For me, when I see somebody with an acute maternal birth injury who's panicking because she can now feel her cervix, and
sure,
I try to encourage them to wait to do physical therapy, and it's remarkable how much they heal, especially if they're really patient. You can wait a couple years,
or even if I've seen people
3 years. Yeah,
when they're done breastfeeding.
Oh yeah,
a lot of like the relaxation, like things.
Oh yeah,
remodel too.
Sure. Yep.
But yeah, I would probably not. A year at least.
Probably wait. Yeah,
for sure.
The longer the better.
Let's see. Oh, for a repeat sacrocolpopexy, do you remove the old mesh? And if you do, which parts?
Yes, I have not done that many repeat sacrocolpopexys. Yeah, it depends. It depends how it's attached. At the sacrum, I don't usually remove it. I would just go on top of the previous, or it just depends where it was attached. Sometimes you go a little above it too and get some new tissue. But yeah, I do remove. I do. A lot of times it's been infected, or it depends on the reasons I go back. Like transvaginal meshes, they're usually in a different spot, so you can go. But after a sacrocolpopexy, I would probably remove it if it just looks like it's doing nothing and it's not, it's just sitting there and acting as a foreign body and distracting from her ability to heal. If some of it looks like it's supportive, I'd probably keep it and just, maybe do one side and not the other. It just depends on what was there.
Yeah. I think that would depend for me too. The one I've done, it actually came out a lot easier than I thought it would.
It usually just pulls right out.
Yeah, like we transected it at the sacrum, and then if you lift and put tension, you can kind of just strip it off the peritoneum.
Yeah.
But I think if I still had some mesh left on the sacrum, obviously I would not.
Yeah,
pry that off. I would sew to there.
Yeah.
I think that was the one. Probably the last question that we had. So we've been here for 45 minutes. I think that's pretty much it. We'll wrap up. Yeah. And this will be saved on the Augs website, all of the Urogynecology Journal content goes to the OG's Instagram page, so you can rewatch, and if you have questions, you could put them in the comments, and maybe the OG social media team will be able to moderate. Otherwise, thank you all so much for joining us. And
we forgot to show Taylor.
Oh yeah, we
have Taylor Swift here.
Taylor Swift here, who I hope if she ever needs a sacrocolpopexy will come to Dr. Moalli.
I hope, yeah.
Taylor, if you're watching, she's the goat of sacrocolpopexys. So stay tuned for the next edition of Beside the Scrub Sink, and we'll talk to you later. Thank you for the effort.
Thank you so
we
much
appreciate
for joining. All right, bye-bye.
Bye.